Arvind's going to take it home and go through a lot of what we talked about, but just a fantastic panel. A lot of expertise.
Thank you. My parents told me that they picked my name starting with an A, so I'm not last in any of the roll calls, but they were not thinking about the presentation. So I appreciate all of you staying in there, hanging in there, and I'm holding you back. And probably part of my talk has already been discussed with the previous debate and discussion, so I'll try to make it quick. And those were my disclosures. So when we talk about weaning MCS, I think one of the messages that got echoed is that you want to keep the shock journey in context because you need to know where you're traveling in that. And in this talk, I'm going to focus on the recovery part, which is a complete explant of MCS. We'll not touch too much about transitioning from a BiV to a uni support because there is some weaning that happens over there too. We're not going to focus on weaning to death because the topic was very clearly picked. It's resuscitated percutaneous. And I have this annoying effect on PowerPoint that I picked because you need to have a constant reassessment of the ability to wean. And this has been shown in the VAD literature. If you don't think about recovery and wean, you will not attempt it enough. Now, how do we attempt? How do we standardize will come into place. It's also important to remember that the readiness to wean is not just about the heart, but also about the body. You want the body and the heart to have been recovered to an extent if you think the individual is ready to be weaned. And I put a star at the liver because you can have renal failure and be on dialysis, it's still acceptable. But I think if you have not reached what we talked about as a metabolic milieu normalized, I think it's probably not appropriate. So metabolic and hemodynamic normalization on MCS support should be the point where you think about weaning. Pre-weaning trial questions that I think about is how severe was the context of the MCS initiation? What like where we're doing CPR for 40 minutes and put in an ECMO? I think that sets a pretest probability for me. What extent of MCS support are we dealing with? A balloon pump weaning is different from an ECMO or an Impella weaning. Did we do something substantial to improve the myocardial ability? If we do a PCI and we think we've recovered the heart, did I do a BiV and I think maybe the BiV will improve? So you want to think about the context of change that you have influenced the heart. And what is the probability of success with what you know right now? And what is the bailout strategy if explant fails? So you want to ask these questions before you move on. And I didn't change the slides based on the past discussions, but I think the use of both hemodynamics and imaging, at least in my experience, makes a difference. And I put there more data points for your NI. Anybody know what NI is? Natural intelligence. It's our brains. In a field where there is so much controversy, the more data points you have, the better it is. And I've seen the discrepancy that you have. Sometimes the wedge looks okay, you have a severe MR which you don't pick up. So I think using both together is extremely important. And if you are a hater of Swan-Ganz, you should not be in this room. We've already established that. So use both hemodynamics and echo is at least my personal bias. So let's talk about each of the devices. And a lot of this is not well established in trials, but when you talk about IOBP Wean, one of the tests that is people recommend and talk, and Jerry did a great job in that paper, I do what I call as a standby test. And that's an example. You put it on standby, the blood pressure is 118/59, that's not bad. And then you move on to these goals that you have on your left side, MAP, blood pressure, cardiac index, CVP, wedge, SVR. These are all within the normal ballpark points that you want to maintain through the wean process. And in the weaning, there are two weaning methods, weaning by ratio and a weaning by volume, which in Jerry's paper, E-STEP's paper, they did a survey, a very small cohort responded, majority stick with ratio wean, and that's what we're used to. And in the weaning, of course, there's no rocket science between 3 and 6 hours. I mean, you kind of use your gestalt 3 to 6 hours, 2 to 1, 3 to 1, then you stop the heparin, you go back to 1 to 1 because you want to stop the heparin, and then the balloon comes out. But I want to remind that the optimization and surveillance for 24 to 48 hours, which I call as the vulnerable period of explant of the device is extremely important because you want to correct the factors with whatever you can. Impella Wean between 2.5 CP and 5.5, it's called as Propella, prolonged Impella. I love the acronyms that are coming out of Impella. But Chope put this paper together. But the context of imaging that we talked about, these were some of the imaging markers that have been studied, not robustly, but a TVI of greater than 12 centimeters, at EF greater than 25%, and the rest listed up there. But you can do two ways of this, a rapid wean from P9 to P2 and a slow wean over a period of time. I think it depends on the context. A 2.5 Impella post-PCI is different from somebody who's chronic heart failure. But I also want to point out that the Smart Assist platform, which is a newer versions of CP and 5.5, actually could be useful because it gives you cardiac output and cardiac power output as a combined circulation effect. So the concept is, as you cut down the P levels, if the output stays the same, then probably the heart is compensating enough that you could use it. Not extremely well studied to remember. These are just a few examples that you can see. The top one, and we have an Impella Wean protocol that we try to do standardized as much as we can. But you notice in the top one, it's a post-PCI cardiac arrest. You go from P6 all the way to P2, going from your left to the right. The cardiac function improvement is not that robust. This could have been a late MI. The bottom one is over somebody who had a VT arrest as a non-ischemic cardiomyopathy. Probably it was a VT that made them go into arrest in 3 days. It looks like it's quite robust as an EF, so you could use this as a surrogate marker. This is a failure to wean. The P8 panel actually probably was not even ready for a wean attempt because you see tachycardia, CVP is 14. You lower it down to P2, none of the parameters are good enough. I think this should come out. And this is a 5.5 or 5.0 wean. Now, Chope did a very nice study looking at what he called as the TIDE algorithm and used PV loops to show systematically, but I think the echo and impeller ramp reduction makes sense. I don't know. What they did is actually, if there was contradictory data, did dobutamine stress and also did exercise testing with hand grip. Reasonable conceptually, but I would struggle with the practicality of this. And in that paper, when he looked at 89 patients, 74% of them passed and they were able to get explanted, and a lot of them needed more than one attempt of this weaning protocol that they used. Tandem heart, not extensively studied. I know Dr. Kars, has done many of these, but physiologically, the weaning protocols are kind of similar to ECMO. I feel like Tandem is similar in that physiology of some unloading and some afterload. So we'll talk a little about ECMO weaning. In ECMO weaning, as you know, we talked a lot of unloading and that PV loop that shows that your afterload goes up. Unloading probably is extremely relevant and important. But in ECMO weaning, there is a rapid wean, as you were talking about, but you can also go gradually a 0.5 liter per minute. But you're looking for arterial pulsatility, cardiac hemodynamics, definitely RV size and function, and then imaging guidance, as we talked about earlier. So this is an example of an ECMO wean. I'm using a lot of imaging up here, but that's one of the data points. A patient who ended up getting an ECMO for transplant rejection gets THYMO, and the post-THYMO, the EF looks a little better. You also have a CP Impella sitting in there, and then ECMO flows down to 2 with an Impella in position, and you see that the EF looks much better. And the ECMO was taken out. The Impella was still left in because it was CP, but the heart is trying to push the Impella out anyway, so that definitely can come out. So it's a treatment that worked, and hence you can probably take it out. RV support weaning is again not been well studied in the RECOVER study, but ideally a CVP of 10 to 12 and a mixed venous of 55% with they call a sufficient RVEF based on echo when you ramp down to 1 liter. So again, there's a bunch of subjectivity to it, and a stepwise reduction was kind of used in it. Transition weaning, we're not going to talk too much about it, but this was put forth in Randava's paper, where we wean a bi-V support, and you gradually wean, and if your RV works okay, sometimes you can use a Y circuit, train the RV, and then move to a 5.5 Impella. That's a transition weaning, which again, I think most people do when you're moving on for transplantation. So this is a summary of, I would recommend this is a good, well-written paper. Randava and Jerry did a great job in putting everything together. The only thing I would add to this flow is have a bailout or a quit plan ahead of time with the multidisciplinary team. You got to know, are you going to put back an ECMO, or we're done here and we're going to stop? Because it does create a nuance if you don't plan that ahead of time. With that, I'll stop. Thank you.
Actually, this was a summary for the session. It was exactly what we need to do. So maybe we'll go a little bit, Anjit, right? Maybe we'll talk to you.
Yeah, no, you've done a lot of work as far as recovery, and how important is it, as far as you mentioned first, like, phenotyping your patients? Are there certain phenotypes that you see that just won't recover outside of the ischemic, population that are non-ischemic? And can you comment on some of your work that you've done looking at recovery?
No, I think it's extremely important, and I believe now there is an ischemic physiology, and we've had patients with 5.5 with post-CAB with pretty much nothing distally flowing at the EF, which is about 10%. I don't think no matter what mechanical support you will put, if you don't have coronary circulation, you will survive, right? In those individuals, I almost say there's no point trying to wean because you're going to crash after. In non-ischemic cardiomyopathies, what you bring up, I think there's a biological variability of recovery, and we're kind of studying that in a recovery model in mice. But it's known, right? We put 100 people on beta blockers and 33% EF recover. Is it because of the timing? Is there a biological ability to heal? I could get a big scar if I heal. Somebody won't get a big scar. So I think this field will probably progress, because one other thing I didn't mention is the next range of devices that might come on the horizon are dischargeable temporary MCS, right? You have Val working on it, and unloading device you go home with. Then how do you modulate recovery and then figure out weaning? So there's a lot that we don't know, I think, in the context of even early phenotyping. But it's important to do the best that we can, knowing what we've reversed before attempting to explant the device.
Impella BTR is also, I think, the study on Impella going, BTR is starting now as well. David?
So, Arvind, this is really awesome. How much do you share with the family? They're going to ask you, you put somebody on temporary support. Do you tell them up front, what you think in 7 days or less, or is it open-ended? Because it's so hard to know. Sometimes you think somebody, they'll definitely recover, and then you're stuck. But how much do you share with the patient and family, or do you say, we'll take it day by day?
Well, I think like all of us do in that journey for shock, it depends on what context it is. The open-ended part comes in when you have a chronic heart failure patient, you don't know what you're dealing with, you take it day by day. I think the best option of reversibility are transplant rejections or fulminant myocarditis, right? We all know. In those individuals, it's easy to say. In them, as we know, I give a 7 to 10 days option. But otherwise, and I think you bring up a very important point, keeping the family in the loop with expectations of where we're heading, with addressing palliative discussions is very key.
Yeah, worst thing is having to shut off a device because there's no pathway.
No, I mean, we've had in the state of Texas, taking off devices is not that easy. I don't know if we've had axillary balloon pump patients who refused to get it out, and 85-year-olds who we thought we could VAD and just didn't work out, stayed in the hospital for 10 months because they said, you're not touching it. And it was not weanable, because every time you attempt, your blood pressure drops. So I think as you're addressing your SKY statement about axillary approaches, my personal belief is if somebody gets a groin pump, their quality of life is miserable. You put in an axillary device, I've had people tell me, just leave me like this, I'm happy in the hospital. Then what do you do?
Daniel, last few comments.
Well, I totally agree with what has been said. My sole question will be, what is a place for manipulation of the hemodynamics with drugs or whatever when there is a first weaning failure? And so how many times do you go for testing with new interventions before going to something else, which is your bailout approach.
Well, I think it comes down to phenotyping on what do you think you've done enough that you feel like you've made a difference. And then I think using some amount of inotropic support to butamine, milrinone to get people off, as long as you know what your journey is, right? Another thing you have to remember is if you're going to bridge somebody to a VAD, they're stable on MCS, there's no point trying to bridge them and take it out and put on inotropes. So I think it's the phenotyping which makes me pretty much decide on how much to do.
We use a lot levosimodar in this condition because it's a good drug because it's a slow acting but also long acting for this kind of difficult weaning. But we first try without it and then we try with when we have some difficulty.
I'm glad you brought it up. So when Estep's paper, he summarizes everything a lot. There's a bunch of studies which looked at levosimendan as an option, but we don't have it here. We need it exported, smuggled.
Dr. Vorovich and Dr. Kumar after that.
One of the things we didn't talk about is weaning VA ECMO with lung issues. I think that's probably one of the toughest ones of how to assess, because you can't really turn it down because they become hypoxic. What is your typical practice there?
Well, I think for assessing your ability to get off of the oxygenator is key, but we wouldn't attempt it unless your PaO to FiO2 ratio is kind of less than 200 and your FiO2 is less than 50%. And I think in some cases, you kind of go to the OR and pause the circulation and then put it on an auto and then see whether you're successful or not. And in some, they've converted that into a VV ECMO to continue the support because you can then ambulate. Because one of the things we didn't touch upon is, at least personally in our center, axillary or upper limb AV cannulation, I feel is wrought with a lot of issues. So you kind of transition what you can from the groin cannulation to a VV ECMO. That's worked out fine for us. But that's important when you're going from AV ECMO. You have to make sure the oxygenation is okay.
So Arvind, can you tell about de-escalation from Impella to axillary balloon pump for people who need stage de-escalation? I didn't see you talk about it. Is it something done or not done in your practice?
I think it's a one-way street. I agree with you. I don't think we've ever de-escalated from an Impella to an axillary balloon pump, because I think you escalate up, and then if somebody is really recovered, at least in my experience, once you commit to a 5.5 Impella, it's a tough preposition to wean it off. Most of these, you make a decision up front on why you're putting it in, and we've done VT, high-risk VT ablations with 5.5. That's the only time where we weaned it off successfully. But I don't know if there's a staged de-escalation that we've done.
IJ, a few last comments.
No, I just think that it's been a phenomenal session, and I think everybody's personal experiences as well as the data and the data gaps are well apparent now, and there's a lot of work to do. So thanks to everybody for the day today. We resume tomorrow morning as